Hey everybody, I'm Allie and I'm going to be doing my presentation over hemophilia. Hemophilia is a blood disorder characterized by a lack of a blood clotting protein. So there are three main types. You have hemophilia A, which is a deficiency or absence in factor 8. Hemophilia B is a deficiency or absence in factor 9. And hemophilia C is a deficiency or absence in factor 11. A and B are the most common forms, but these mutations occur for all three forms on the X chromosome. So it's a mutation or deficiency on that chromosome. Here I have a diagram that shows what occurs after you have an injury. This is what the blood vessels look like. So for a healthy person, injury blood vessel clotting factors are activated. They have platelet plug formation, and then they form a stable plug clot. So that means they bleed a little bit, they have the formation, and then it's plugged. They stop bleeding. But with a person who has hemophilia, they have a lack of clotting factor. So they have weak platelet plug formation in an incomplete and or delayed fibrin clot. So that means that their blood does not clot, so they don't get that bruise. They don't get that like stopping of the cut, you know? They don't have that. So that means they'll bleed for a long time, and for different forms of hemophilia, that can have different effects. So some signs and symptoms are people with hemophilia have prolonged bleeding, like I said. Bleeding can be internal, like at the muscles and joints, or it can be external due to minor cuts or injuries. The severity of bleeding depends on the amount of factor that they have or that they produce naturally. So mild hemophilia means there is approximately 6 to 49% of naturally occurring factor 8, 9, or 11 in their blood, and it's usually only detected after a major surgery or procedure or injury. Because they do have at least somewhat of enough clotting factor to stop bleeding. Usually they're just like, oh, I bleed really, really bad. They don't understand that it is hemophilia. Moderate hemophilia means there is about 1 to 5% of factor 8, 9, or 11 in a person's blood. Those with this form have bleeding episodes after wounds. So if you have 1 to 5%, that's a very, very low percentage, and you will have excessive bleeding. And then severe hemophilia means there is less than 1% of a factor in the blood. People with this form are prone to bleeding episodes, especially in the bones and joints, and excessive bleeding after injury. Like, it's very, very bad for them to bang their knee up against a desk. It's very bad for them to get even a minor scratch from like a dog. It's very, very scary. They have to almost live in a bubble. So diagnosing hemophilia. It's usually done by screening tests and or clotting factors. So screening tests show if blood is clotting like it should be. Different types of screening tests are a complete blood count or a CBC, an activated partial thromboplastin time test, a prothrombin time test, and a fibrinogen test. A CBC measures the amount of hemoglobin, size and quantity of red and white blood cells, and platelets in the blood. An APTT and PT test are the amount of time it takes for blood to clot. If it takes a long time for your blood to clot, that's a very big symptom of hemophilia. A fibrinogen test sees how well a person can form a clot. If it takes you forever to form a clot, a big sign. Clotting factors are necessary properly to diagnose which form of hemophilia and the severity of the case. So they use this test to say, okay, you probably have hemophilia. Let's see how bad of a form you have. So we have the treatment options. The foremost treatment option is to replace the missing factor. This allows blood to clot as it should. Doctors usually prescribe clotting factor concentrates, which are injected into a person's vein or intravenously. This is a photo of kind of what it looks like. This is, what it would look like in the blood vessel. And they're just injecting the antibodies into this person's blood vessel. And they're injecting, in this case, factor 8. So this person has hemophilia A, and they have a lack of factor 8 in their blood. Episodic care is used in an attempt to treat bleeding episodes. So usually this is a person who has a nosebleed and it will not stop bleeding. Or they cut their leg and it will not stop bleeding. That's in it happens out of the blue. You didn't expect for it to happen. Prophylactic care is done to prevent future episodes from occurring in the future. So this is all the steps we take so we don't have have to do episodic care. Currently, hemophilia treatment can be done at home by family members to allow quicker reaction time and less bleeding. Thanks to the modern world, people are not having to go into the hospital to have treatment. They can do a lot of this at home. So, the two most common types of clotting factor concentrates are plasma-derived and recombinant factor concentrates. Plasma-derived factor concentrates come from human plasma, so they come from people. That's usually when people donate their plasma. This is where they get it from. And it's separated into smaller components. It's then freeze-dried and then tested to make sure there's no viruses in that person's blood that they will pass on to whoever will get this. Recombinant factor concentrates are usually genetically engineered, which is insane that we have the kind of modern medicine to do this. They don't contain any plasma or albumin, so there's no way for a person to get a virus or to get sick off what they're given. So it basically is like, this is not why you're sick. It's almost like a perfect concentrate. This is the one I would want to get. Hemophilia does not replace factor VIII, but replaces the function factor VIII performs, or a different factor. But basically, it's used to prevent or diminish the rate of bleeding episodes, and it's injected under the skin or intravenously again. But it's there to replace the function, but not actually replace it. So it's just doing what the factor is supposed to do without actually injecting that factor into your blood, which again is insane how your body can just go with the flow like that. DDAVP or stymate are medications that send out factor 8, 9, or 11 from its locations along body tissues. For those with moderate or mild hemophilia, these medications can increase their own factor levels, which can also mean that they don't have to use clotting factors during a bleeding episode. DDAV is intravenous and stymate is given by nasal spray. So this is also very crazy to me. Basically, this can increase the amount of factor that a person with hemophilia has in their body, so they can like slow down using treatments. Their body learns how to do it itself. Again, insane. Amicar is medicine given through the vein or by mouth in pill or liquid form. It blocks the substance located in saliva that causes breakdown of blood clots. So this ensures that whatever's in your saliva is not going to break down your blood clots, and your blood clots are strong. So some fun facts about hemophilia. Hemophilia A is called classic hemophilia. It's usually the most common diagnosed type. Hemophilia B is also referred to as Christmas disease because the first person diagnosed with it his name is Stephen Christmas. People with hemophilia can develop inhibitors. So basically these are antibodies that can inhibit the functionality of a person's treatment that they get. Let's say they get some kind of intravenous plasma treatment and they develop inhibitors. So they develop antibodies and their body stops reacting to the treatment. So then they have to find another treatment and hope that it doesn't develop inhibitors to that as well. It can get really, really expensive and it can take a big toll on your body because you're trying to get treatment and none of them are working. It's very, very sad. Here I have a photo about the X-linked recessive, hereditary flow. So you have a father that's affected and a mother that's unaffected. So they could have a son that's unaffected, a daughter that's a carrier, a son that's unaffected, and a daughter that's a carrier. And then you have a father that's unaffected and a mother that's a carrier. They could have a son that's affected, a daughter carrier, a son unaffected, and a daughter unaffected. You can have a very weird combo. But with a father, it's usually going to be passed on to the daughter. And with a mother, it's usually going to be passed on to the son, but it can also be given to the daughter, but they'll usually be a carrier. So we have some statistics. Hemophilia A impacts approximately 1 in every 5,617 male births. It's much more prevalent in males than in females. There are about 30,000 to 33,000 males with hemophilia in the United States alone. Over 50% of those diagnosed with hemophilia A have severe hemophilia. Hemophilia B is 4 times rarer than hemophilia A, so that's why hemophilia A is classic hemophilia. And hemophilia C occurs in every 1 in 1,000 people. Out of all 3 types of hemophilia, hemophilia C is the most rare. It'll be A, B, and C, literally. So this photo is showing legend represented as count ranges. So, for example, California and Texas had some of the biggest amounts of people that were diagnosed with hemophilia. And a lot of these, like, northeastern states. That means that they had either less than or equal to 1,000 people in their state alone with hemophilia. So like in Georgia, we had about 700, so a good amount. And then places like up here with Wyoming, North, South Dakota, all those are like 6 to 99 people. It's not percent, it's like people. So hemophilia is really, really rare. There's not a lot of people that get hemophilia. A rare disorder is about 200,000 people and under. And hemophilia only affects about 30,000 people or males in the US. So it's very, very rare. So here we have the prognosis. Those with hemophilia can have a normal lifestyle and lifespan as long as they continue to have adequate treatment and properly equip themselves for possible bleeding episodes. It is important that they exercise on a regular basis, maintain a healthy weight, and a good dental hygiene. If you have hemophilia, you need to try to keep your body healthy in all the other ways as well. So here it says since 1960, life expectancy for hemophilia patients has gone from 20 years to 77 years. So in the span of 60 years, it's gone up like 50, almost 60 years. So that's insane. Here we have a healthy person and a person with hemophilia. And it shows how it's not working after an injury. So current research shows that there is hemophilia inhibitor research study. That's a certain study that the CDC does, and it looks into why some people develop inhibitors. So like I talked about earlier, why do they develop antibodies to their treatment? Why doesn't their body want to have treatment? Scientists are looking for a way to prevent inhibitors so that people can continue with the treatments, so they don't have to change treatments. The CDC Hemophilia A and Hemophilia B Mutation Project, or CHAMP and CHBMP, documents the number of mutations that have been found to cause hemophilia worldwide. So there's all different kinds of mutations. The CDC tracks it through these studies and through this research. There are more than 2,000 documented mutations for factor VIII and approximately 1,000 for factor IX. This allows doctors to know the patient's clotting factor production and its function. It also helps determine whether genetic testing is necessary for family members and whether a person could possibly develop inhibitors for their treatment. So if they have a certain type of mutation, they may be able to develop inhibitors, and they also may be able to pass it to their family more than a person who doesn't. So thank you guys, and I really appreciated it, and I hope you guys have a great summer.